Hello, everybody. This is Dr. Al Heuer. I am a professor at Rutgers University, their School of Health Professions. I am also the co-editor of Egan's Fundamentals textbook, as well as two other textbooks in respiratory care. I'm an adjunct professor in the respiratory care programs at Rush University and at County College of Morris. But I'm coming to you today for a very, very different reason. I am the co-owner of A&T Lectures with Terry Shenfield. And today I'll be presenting to you a PowerPoint on capnography practical applications. As such, we're going to examine the indications, contraindications, including some of the newer data out there where we use end-tidal CO2 to help guide the team during advanced cardiac life support. Whereas where you can measure end-tidal CO2, it can provide some very valuable information to the team. Most importantly, we'll be looking at some of the various waveforms, so some of the ways in which the capnograph, so it's a graph, that can vary from what is normal, looking at common conditions that can contribute to that. With that, let me get started. I want to thank you for joining us today. Hopefully you enjoy this presentation, and hopefully you come back to us for more of your CEU and education needs. Thank you. Some of the specific learning objectives we're going to focus on today are explaining the indications for end-tidal CO2 monitoring, illustrating some of the equipment that's used to do so, review some of the related research and literature, define what is a normal end-tidal value, define what are abnormal values and waveforms, and discuss some of their causes and ways to remedy those problems. We'll also identify different waveforms, and probably most importantly, I'll furnish you with additional resources should you want to drill down more and learn more about this topic. A good place to start is probably reviewing some related terminology. Capnography, I emphasize the graphy, is the analysis of the waveform or the graph. Often it's accompanied by a numeric value of the end-tidal CO2. Capnometry is the actual numeric value. Again, they're not mutually exclusive. Much of the equipment that's used to monitor end-tidal carbon dioxide will have both the graph and the number. A still related but somewhat different term is colorimetry, which is when I say dichotomous, it's a measurement of, is it purple or is it a yellowish sand color, and what that actually means. In general, a change in color with the colorimetric indicator is a good thing, and it suggests that, for example, when used for intubation, that the endotracheal tube is in the trachea and not in the esophagus. However, there are limitations, and colorimetry can be less reliable than a waveform. For instance, in CPR, you have carbon dioxide buildup in the tissues and in the blood, but that blood may not be circulating very well. And as a result, there's little CO2 that may be reaching the alveoli in order to be eventually exhaled. So there can be little color change despite the fact the endotracheal tube is in the same or proper place. For a high CO2, the color may still say yellow after an initial change because, again, the level is so high, there's so much CO2 that's being expelled that the color change does not happen as it would without a CO2 that's that high. Some of the indications we'll focus on are, for example, monitoring ventilation or the adequacy of ventilation and gas exchange, such as that may occur in a mechanically intubated patient who perhaps is weaning on pressure support, or a spontaneous breathing patient who may have received some sedation to accommodate a procedure, or may have a progressive neuromuscular disorder resulting in, number one, the weakness in the respiratory muscles and the associated or concomitant buildup of CO2 because the minute ventilation is dropping. In addition, and as a point that I just alluded to, is monitoring patients who are moderately sedated. The term used to be conscious sedation, but we've gotten away from that. And generally speaking, when medication is administered to sedate a patient to facilitate, say, endoscopy, a colonoscopy, or a bronchoscopy, that those medications are given to achieve this moderately sedated state, or like a twilight sleep. However, those same medications can result in a suppression or depression of ventilation and can cause the buildup of CO2, which can be detected if the patient is indeed interfaced with capnographic equipment. Another traditional indication is what I alluded to earlier, and that is monitoring or verifying the placement of an advanced airway such as an endotracheal tube. An additional indication, and somewhat newer than some of the older traditional ones, is to check the effectiveness of cardiac compressions during a resuscitative effort. With all else constant, the better the compressions, the higher the CO2 level that is going to be indicated on capnography. A still even newer indication is to use capnography as a predictor of mortality in diseases or conditions like acute lung injury or ARDS. That is, the higher the end-tidal CO2 for a sustained period of time, the worse the outcomes in acute lung injury and ARDS. Now, there's a variety of equipment and supplies that are used in capnography. There's also equipment that's used in related aspects of monitoring a patient. Okay, so we have colorimic detectors. So it's related to end-tidal CO2, certainly, but in and of itself does not provide neither the graphic depiction nor the, if you will, value, the number. However, the equipment and supplies needed to show the graph and to show the number are not always available. So we can resort to what's called colorimic detection. And I've referred to it earlier on in this presentation. I'll probably refer to it a few other times in this presentation as well. So this is where you have a device that you can actually put in line once a patient is intubated in order to determine or help determine whether or not the tube is properly placed. And if in fact the tube is properly placed, the color will change from purple to sort of a yellowish, and back to purple, and back to yellow. Again, not quite as reliable as what you would have in a capnograph depiction, but also can provide some very, very helpful information when establishing an advanced airway. It would be best not just to rely on the colorimic, but also looking at things like saturations, listening for bilateral breath sounds, looking at the patient's color, and things along those lines. But in the absence where waveform capnography is not available, the colorimic can certainly add value in a clinical situation. This shows a combo cannula, which is capable of both administering O2 or supplemental oxygen and concomitantly monitoring end-tidal CO2. So you'll see the actual orange connection there, the male connection. That would be for monitoring the end-tidal CO2. And the female star lumen or small bore tubing would be for administering the oxygen. The caveat here is if the oxygen flow is at about 5 liters or more per minute, it will render the accuracy of end-tidal readings not very reliable because the oxygen will be diluting the CO2 that's exhaled by the patient. So these devices can be useful, but they're not flawless. So the good news is we have end-tidal, capnographic capabilities in many clinical settings. Certainly is the good news. The bad news is there's a lot of different systems that are used, and there's a lot of things that can affect their accuracy. A lot of factors. And with this particular example here, obviously this patient is not connected to a ventilator, and this is illustrative, but it's showing you an endotracheal tube out of this gentleman's mouth, and it's showing you that the actual adapter, the end-tidal CO2 sampling tube adapter, is facing downward. So you can think about what can happen. Moisture. It may be moisture from condensate. It may be moisture from what the patient's exhaling. But it, again, could be condensate from the humidifier, etc. But irrespective, water gets in that tubing, it's going to affect the accuracy. So, the cure for this, if this patient was really connected to a ventilator, is you're going to have to change out the end-tidal CO2 adapter. And that's really what you need to do. The problem with that is now you're opening up the circuit and you're opening up and exposing the patient to the potential for to introduce microbes into that sealed circuit, if you will. So the point of it is, if you can avoid it altogether, you want to get your end-tidal CO2, but you want to try to, if you're using a sampling line adapter setup, is you really need to try to make sure that the sampling tubing itself is facing upright. Talk to the nurse and nursing assistant to say, hey, if you're going to roll the patient, I can give you a hand, or if I'm not available, if you could just really concentrate on keeping that upright. Otherwise, it's not just having to change out the actual adapter, but it's also exposing the patient to, the introduction of microbes into the ventilatory circuit, which can, cause a respiratory infection, VAP, and even worse than that. So just keep that in mind as well. One of the newer indications is to actually, again, look at capnography during CPR to assess chest compression quality, also to detect the return of spontaneous cardiac activity. In the next slide, I'll show you a depiction of what that would actually look like. In some cases, capnography can also serve as objective data for the decision to cease a resuscitative effort. So for example, if the end-tidal CO2 is exceptionally low, let's say it's less than 5 or 6 or 7, and it's been kept that way a sustained period of time, it's suggestive that the blood circulation has been down for a long period of time, and that the likelihood of a successful resuscitation is not good. The other end of the spectrum is when the end-tidal CO2 is very high, and it's very high for a very long period of time. It may also be an indicator that not so much on the circulatory side of things, but that on the ventilatory side of things, that the patient has not been ventilated well, and for a long enough period of time, that can cause irreversible damage. Some of the additional research that's been done was published, for example, by Sanders in the Journal of the American Medical Association in 1989, where these researchers determined that end-tidal CO2 correlates to outcomes in CPR. And I'll discuss some of those thresholds in subsequent slides. A 2005 study compared intubations that use capnography to confirm ET2 placement versus other methods, and it basically showed a 0% unrecognized misplaced ET tube versus a 23% unrecognized, misplaced ET tube when capnography was not used. So the moral of the story with this slide is to confirm ET tube placement with waveform capnography. Some of the thresholds to consider regarding capnography and CPR are as follows. I'm always a little cautious to use a hard and fast cutoff, but just as a guideline, when the end-tidal CO2 is considerably less than 15, it's suggestive that the CPR needs to be improved. If it's greater than 15, it's also suggestive that the CPR, particularly the compressions, are adequate. In addition, the return of spontaneous cardiac activity can also be indicated when there's a sudden increase in the end-tidal CO2, sometimes as much as 10 or 15 or more within a few seconds, to a level that's in the range of 35 to 40. Again, that would be suggestive that, again, cardiac activity, that the heart has started to pump effectively for the patient. So when the resuscitation team, during a code blue, during CPR, advanced cardiac life support, when we're actually doing compressions on the patient, under the best of circumstances, those compressions are emulating about 25% or so of perfusing pressures. So certainly nothing that approaches normal, but potentially adequate to maintain cerebral oxygenation, all right? And one of the ways we could actually determine the quality of compressions, as I was alluding to earlier, is by looking at waveform capnography. And what you will see, again, looking at the various values, is you're really aiming for a capnographic number of about 15 or higher. And you see that in about the first 2/3, working from left to right. About the first 2/3, you actually see, after about 30 seconds of CPR, you see the waveform capnograph a little bit north of, it's probably around 18, something along those lines, approaching perhaps around 20. And then as you move over to the right, you see a sudden jump from, again, about 15 to 18 all the way up to perhaps 35, something along those lines. And that's typically associated with when a patient would, if you will, resume spontaneous cardiac activity. So it's not just that their heart is beating, is that it's the pump is working, that you're now circulating blood, and indeed, depending upon whoever's running that code, and whoever is handling the monitor and communicating using closed loop communication, they may advise the person doing compressions to stop, do a pulse check. If the patient has a pulse, then and they have a waveform that looks like this, you're probably going to continue to ventilate them with 100% oxygen, but it's certainly suggestive that the patient heart has basically both electrically as well as mechanically has kicked in. And again, the depiction here is you have a sudden jump up on end-tidal CO2, again, in this case from about the mid-teens, mid to upper teens, all the way as high as about 50. The jump there, by the way, when it does go up to about 50, maybe a little north of 50, it really is showing that there's been a buildup of CO2 in the system, and now the heart is starting to pump blood effectively, and that blood is making it back to the lungs. There's gas exchange taking place, but if anything, the end-tidal CO2 is a little bit higher, and you could see it kind of start to dip down a little bit, towards the right end of this particular graphical depiction. Very useful information, end-tidal CO2 in a resuscitative effort. Another major indication for capnography is monitoring ventilation. Whether it be spontaneous breathing patients, who, for example, neuromuscular patients coming in for their regular checkup, or COPD patients that are doing likewise, that don't have a neuromuscular disorder, but they're, if you will, prone to retain CO2. There's a Dr. John Bach, who's at a university hospital in New Jersey, northern New Jersey. He does a lot of work with neuromuscular patients. And when they come into his office, he will invariably measure their end-tidal CO2. And he has found that over a period of time, that the increase in their end-tidal CO2 will correlate with the progression of their disease. So as their muscles get weaker, the CO2 will tend to build up and be able to be measured in the context of capnography. With mechanically ventilated patients, looking at continuous non-invasive ventilation, so we can actually measure the adequacy of, if you will, the non-invasive augmentation that we're providing the patients with. For both intubated and non-intubated patients, it can, if you will, talk to the appropriateness of the settings. If it's non-invasive, is the difference between the I and the EPAP, the delta P, is that sufficient? If there's a backup rate, is the rate sufficient to keep the end-tidal CO2 within targeted levels? Also with mechanically ventilated patients, end-tidal can be very useful when, for instance, patients, number one, are being assessed for weanability. So if their end-tidals are very high, they may not be a candidate for weaning. Or if they are weaning and we see a trend where their capnography is increasing over time, over the course of hours during the day, they may be tiring out. They may need to be put back on full support. So let's look at the numbers. The normal targeted numbers that we're looking for pH, 7.35 to 4.5. But in order to, if you will, maintain that pH within the targeted levels, the end-tidal CO2 would be in that 30 to 43 range. So in order to normalize with all else constant, the pH, the end-tidal CO2 would be 30 to 43. And it correlates to a PA CO2 of 35 to 45. So keep in mind that with all else constant and under normal conditions, the end-tidal CO2 will be below, okay, will be beneath what you'd get in a blood gas in the PaCO2 rather. You'll also notice that the scale is not linear in that the difference between end-tidal CO2 and PaCO2 is greater at the lower end of that scale. So at the lower end of the scale, you'll notice that a end-tidal CO2 of 30 correlates with a PaCO2 of 35. On the upper end of the scale, the difference narrows, with the end-tidal of 43 correlating to a PaCO2 of 45. So that difference is only 2. It narrows from 5 at the low end of the scale to 2 at the upper end of the scale. This slide just builds on the prior one by basically looking at your ranges, if you will. So PaCO2 greater than 45 correlate to an end-tidal CO2 of 43, and likewise with the alkalosis in the bottom part of the slide. That, you know, if you're getting a pH that's greater than 7.45, if you will, the indicators or the correlating PaCO2 would be greater than 35, the end-tidal CO2 would be greater than 30. The question arises, broadly speaking, how do you respond to an abnormal CO2? And this comes up clinically, it comes up with our credentialing exam candidates, etc. But so, for instance, if you have an end-tidal CO2 and you have reason to believe that it's accurate, it's been correlated to a PaCO2 via a blood gas. So if you have an end-tidal CO2 that's high, you need to increase ventilation. Okay. If you have an end-tidal CO2 that's low, you need to decrease ventilation. However, what often happens is, the clinician scratches their head and says, well, do I, increase, if the patient's on mechanical ventilation, do I increase the respiratory rate? Do I increase the tidal volume? And the purpose of the next slide is to really talk about that specific issue. So the preceding slide was showing you, various conditions, most notably a respiratory acidosis or alkalosis. So for a minute here, let's focus on the respiratory acidosis. I'm also an item writer for the National Board for Respiratory Care, so I write a few of the questions that appear on the exams. And while the clinical simulation portion of the exam is going to be going away in 2027, there's still going to be cases, if you will, that are built into that exam. And also from a practical perspective. So let's forget about licensure and credentialing, et cetera, et cetera. But from a practical perspective, when you have a patient, do blood gas on a patient, the patient has a respiratory acidosis, and let's say they're on a ventilator, the question is often, do we work the tidal volume or do we work the respiratory rate? Okay, so just a little bit of critical thinking. It's not magic or anything along those lines. Is examine current tidal volume relative to recommended. 6 to 8, 5 to 8 mLs per kg. So if you have a patient, I'm about 5'9.5". My ideal body weight is probably about 75 or 80 kgs. So a reasonably good tidal volume for me is between 450 and 500. Well, if my tidal volume is already pinned up at 500 or 550, so I'm at 8, 8 or maybe even a little north of 8 mLs per kg. Perhaps my ventilatory pressures are fine, but I'm still pushing the flight envelope when it comes to high end of normal for my tidal volume. Then you're going to probably, examine the respiratory rate. If you need to correct for a respiratory acidosis and your tidal volume is pinned up, to the northern end or maybe slightly exceeding that 8 mLs per kg, but your respiratory rate maybe is only 14 or 16, actually look to work the respiratory rate. So again, in this particular slide, this example is really looking at, if you're seeking to decrease the end-tidal CO2 or the CO2 that's in the serum, and the tidal volume is currently, in that lower end of 4 to 5 mLs per kg, then consider increasing it, subject to maintaining your plateau pressures less than, equal to or less than 30, or your driving pressures less than 15. So it's not limitless. You're not going to increase your tidal volume irresponsibly, or if the patient, you're using ARDS-net and the patient has very, very stiff lungs, then, you may just be left with no alternative than to work the rate. But when you have that latitude and the patient is, their compliance is reasonably okay, then in that particular example, consider increasing the tidal volume. So likewise, you examine the current respiratory rate relative to variables such as normal range, 8 or 10 to 30, I ratio. Is there any evidence of autopeep? Because if you go too high on the respiratory rate, you're going to be, if you will, taking time from exhalation, and there may be insufficient time for that patient to exhale fully. So you could be like fixing one problem and maybe contributing to another. But where you have the respiratory rate at the lower end at, let's say, as I said, 12, 14, or 16, and the patient has a respiratory acidosis, particularly if the tidal volume is already fairly large, then, work that respiratory rate. So this is a normal or something, at least as far as the, if you will, the number, if you will, the capnometry. In this case, it looks like the waveform is peaking somewhere in the upper 30s, 37, 38, something along those lines. There is a pseudo plateau. It is kind of sloping upward ever so slightly, but a pseudo plateau. It's regular. And again, the other thing that I stressed a little bit in some of the prior slides is that there's a gradient, okay, between the end-tidal CO2 and the PaCO2. And that gradient is not a linear relationship, but it's normally a difference of about 4, something along those lines. Peeling away a few of the, if you will, layers in the onion here and looking at, well, what actually constitutes this normal waveform and what are the different phases, okay? So for the first part here, the line between A and B, essentially no end-tidal CO2, owing to the fact that it's either a pause in between breaths or you have the beginning of the exhale process, very beginning of it, but whatever's being exhaled is not participating in gas exchange. So it's just not, it has essentially no CO2, and it's suggestive, again, it's a pause between breaths, or it's the very, very beginning of exhalation, and there is no CO2 in that gas. So after that normal A-B segment, okay, where you're kind of in between breaths, you now have this B-C segment of a capnograph. And so you have a rapid rise in the slope, if you will, up to, again, I'm interpolating here, somewhere, let's say 37, something along those lines. And what's actually occurring physiologically is the CO2, it's mixing, if you will. Initially, you don't have any alveolar gas. And then as you rise here, you actually have more of the CO2 that's being exhaled and being measured. You got this rapid rise in CO2 concentration that is known as phase 2 of the capnogram. Looking at, if you will, phases 3 and 4, but let's focus for a moment on phase 3. Phase 3, you have what looks to be a steady state, a plateau. It may not be a perfect plateau, but you're looking for something that's close to it. And what's happening there is you're not mixing a gas that hasn't met the, gone down to the alveoli with gas that has. You are measuring, basically alveolar gas that's been exhaled. And it's a consistent, it's a homogeneous gas that's fully participated in gas exchange, and therefore you have a leveling off. And that's really what your capnograph or your capnometry, that's when it's actually measuring what the end-tidal CO2 number actually is. And again, interpolating here, it looks to be, in the upper 30s to perhaps as high as 40. And again, in most cases, just simply referred to as phase 3, or in this particular depiction, it is the CD, line or portion of the capnogram. And then just looking a little bit further here, you actually, again, your end-tidal value, and now the patient is actually exhaling, and you get this rapid drop in the breath. They're in between breaths, going down to your capnogram level of 0, in between breaths there, and then you're ready to kind of start this whole cycle yet again. So this slide is really showing you have a reading in that first breath there. It's probably around 30, 25 or 30 or something along those lines. The next breath it's less, the next breath is even less. Okay. So what probably happened here, again, we don't know for certain because we don't have enough information, but if we knew that this patient was being intubated, okay, and that this tracing was monitored during the intubation, it would be suggestive that the tube did not end up in the proper place. The first few breaths, there was some end-tidal CO2 because there was CO2 buildup in the hypopharynx. So the area around the glottis, but again, not definitively in the trachea, because we don't see that good formation of a plateau, a rise, a plateau, and we don't see the repetition of this waveform. And this slide is basically showing you an increase. Okay, you're seeing this rise, this sharp rise. It's a sharp rise. It looks a little like a shark fin, and it may well be indicative of some form of an obstruction. Could be an obstruction in the airway where you're not getting that sharp exhalation. You're getting some resistance to it. Okay, so this could be an equipment problem. It could also be a patient problem. It could be that the patient is becoming bronchospastic, and there is, if you will, an obstruction to exhalation. So the shark fin pattern is one of the patterns that you'd look at or look for with patients that have asthma that are prone to bronchospasm, assuming you've eliminated all of the equipment-related causes. In this particular capnogram, it is indeed abnormal, and just look at that, we compare it to the normal, it fails to basically maintain a plateau. When you think about what's actually happening, it's failing to do that because there's some sort of a leak, there's some sort of introduction of, I'm going to say, room air. And for all intents and purposes, room air has essentially very, very little CO2. So it's almost, for practical purposes, from the standpoint of the equipment used in capnography, it's essentially imperceptible. Okay. Now let's take a further look. What can cause a leak? So one of the things that can cause a leak is there's an issue with the endotracheal tube. Okay, that the endotracheal tube has become dislodged, or maybe it is, at the vocal cords themselves. So, it may be positional. The patient, when they're positioned a certain way, it has a good seal, but then when they're not, there's not a good seal. It could actually be a problem with the cuff itself. The cuff could be blown. Often when the cuff is blown, you're unable to even, reach that peak that we saw there. But for all intents and purposes, in this case, it's approaching the peak. Think about it. It's approaching the peak, probably peak airway pressure, and then that leak is developing, and the alveolar gas is escaping, and therefore you're unable to measure. Artificial airway that is either too small for a patient, so maybe a large male has an endotracheal tube like a 7.0, because maybe that's all they can get in the field. It was enough to get the patient safely to the hospital, but now they're there, and you're repositioning the patient, etc., and there's issues along those lines as well. So just think about anything that could cause a leak around that cuff could depict or show itself in a capnogram, such as is shown in this slide. In this example, you have an increase in that plateau. So it's initially around 37, then it goes to 39 or 40, and then maybe it goes to 42 to 45. And again, if this happened over minutes and hours, it would be suggestive and point to a decrease in the minute ventilation. So perhaps the patient who's on pressure support is getting tired. Perhaps there's also an increase in CO2 production where the metabolic rate is going up. Or there's a rapid rise in body temperature, such as that may occur with a severe infection or even an injury of some sort to the hypothalamus. That's basically the thermostat for the body. There's also some less common causes of this sort of phenomenon where the patient has had a laparoscopic surgery. They've had a lot of carbon dioxide gas pumped into their, if you will, abdomen, if it's an abdominal surgery, so that the surgeon or surgery team could see what was going on down there and actually do the procedure. That CO2 is evacuated, but not all of it can be evacuated. So the body will absorb that. It has to go somewhere. It ends up in the bloodstream. It ends up, working its way to the alveolar capillary membrane to be exhaled. The other example would be not real common, but does happen. I've personally worked in 2 trauma centers where an individual may come in with a tourniquet. The trauma surgeons have gotten a hold of the patient. They're working on the patient. They've stopped the bleeding. They released the tourniquet, but you've had all of this, if you will, anaerobic metabolism that's been going on, buildup of CO2. Again, the CO2 now is no longer trapped in the distal or beyond the tourniquet. It's now allowed to actually enter the bloodstream, and it needs to go somewhere. So in this example, you see that although a plateau is achieved with a capnogram, it's increasing over time. Now, again, just for illustrative purposes, we're looking at 3 breaths, and you're looking at an increase over 3 breaths. In reality, this could occur over, over minutes, more commonly, perhaps over hours. But irrespective, this is really showing you a depiction of a gradual increase in end-tidal CO2, and a lot of things can cause this. One of the things is that the patients received, 5 milligrams of morphine sulfate, MS, morphine sulfate for pain. Now that's not a ton of morphine, but if a patient is naive, okay, if they do not take narcotics or they don't take, if you will, analogs of those medications, that share some of those same receptor sites, the patient may be very sensitive to that 5 milligrams of morphine sulfate, and it may suppress their drive. So they're still probably breathing because we see that the waveform depiction is showing you these breaths, but they're not breathing deeply, and you have this buildup of CO2. Just to be clear on this, one of the main reasons, we talked about the indications for end-tidal capnography. One of it's not new, but I would say newer indications, and it really is the standard of care, is that when a patient's receiving moderate sedation for things like bronchoscopy or endoscopy, colonoscopy, and other procedures. So we used to call it conscious sedation, now we call it moderate sedation. The standard of care is pretty much to measure end-tidal capnography to help ensure that were not in a significant way depressing their respiratory drive. And in those cases, so that, it could be illicit drug use. You read and you hear about that, but it could be it's prescribed. It's very intentional, but we want to monitor the patient to make sure that whatever we've given them for sedation hasn't knocked out their respiratory drive, or suppressed it sufficiently where the end-tidal CO2 or the PaCO2 ultimately is not excessively high for the patient, causing an acidosis as some sort of a danger to the patient. And this waveform is showing you the opposite. So this capnograph is showing you the opposite of the preceding slide. Preceding slide, it was gradually rising over time. Again, it's compressed here over 3 breaths, but the inference is over a period of time, minutes, that the prior slide was showing a rise. This particular slide is showing you the opposite, where you have a decrease in end-tidal CO2. So the good news is that the waveform is good. The waveform plateaus, so it looks like it's very measurable. It doesn't look like there's an issue of a leak or anything along those lines. But the real problem is that it's gradually decreasing. So it's suggestive, strongly suggestive, assuming this is an accurate, if you will, depiction of the capnograph, is that the patient is hyperventilating. And then you drill down further and say, well, what can cause, hyperventilation? And so some of the things are not necessarily, respiratory in nature. So you get a patient who's in pain. Patients who are in pain, they may also be anxious because they're in pain. So you got that kind of double whammy there. So it may be something that their pain is not being managed adequately, therefore causing a decrease in exhaled CO2 and ultimately an alkalotic condition. Okay, so increase in respiratory rate. Again, what are some of those things that can cause that? Increase in tidal volume. So you get patients who are, let's say, they have a respiratory alkalosis, but it's not really a respiratory alkalosis. It looks like one, but it's actually a compensatory mechanism for what would otherwise be a metabolic acidosis. So they may be blowing off CO2 because they have like Kussmaul's breathing, because they're in a diabetic crisis. And in that case, it's not just the respiratory rate, but it's also the second bullet here, the increase in tidal volume. So that may be the issue as well. A decrease in metabolic rate, where you're cooling a patient very rapidly for a therapeutic, for targeted temperature therapy. And again, that last one is really related to those last 2 bullets, a decrease in metabolic rate, fall in body temperature, or not the same, but they're certainly related phenomenon that need to be considered when you see a waveform like this. So focusing a little more in depth on what happens with the bronchospasm waveform. And again, to remind you guys, I referred earlier to the shark fin shape that may accompany a severe bronchospasm if a patient also has end-tidal CO2 in place while they're having the bronchospasm. So think about what happens. The alveoli unevenly fill on inspiration. They also empty asynchronously or unevenly during expiration. So you get this asynchronous airflow on exhalation, which dilutes the exhaled CO2. So what it ends up doing is altering the ascending phase in the plateau. So you have a slower rise in CO2 concentration. You got the characteristic pattern, which again typifies a bronchospasm. And again, it's crudely referred to as a shark fin shape to the waveform. So building on the prior slide, where you have, if you will, patients bronchospastic, perhaps they're an asthmatic patient who's their asthma is not well controlled, and they're in in severe bronchospasm. You have basically uneven emptying of the lungs. Okay, so the graphical depiction, the top portion in sort of orange, is comparing the bottom to, the top is a normal, the bottom in blue is an abnormal, capnographic waveform. Now I will tell you, again, that shark fin, I'm putting that in quotes, shark fin depiction is really saying having difficulty, if you will, reaching a steady state because the alveoli are emptying unevenly and slowly. So therefore inhibiting the ability to achieve, if you will, that plateau, that kind of classic and I'm going to call it a quasi-plateau. It's not completely flat, but it's, it's almost flat. In this particular example, it's showing you in blue there, that bronchospasm, where it's more like a shark fin, and it can get more dramatic than this. It can be even more sloped. And I would caution anybody looking at this slide to say, well, I walked in a patient's room, I saw the shark fin, and I immediately thought they were bronchospastic. I really caution you from doing that, because other things can actually, that inhibit exhalation and achieving that steady state, can also contribute to it. But it would be, I would say, you walk in a patient's room, you're looking at the shape of the waveform, and you're seeing this, and then you kind of have, the patient may have a history of asthma if they do. And now my index of suspicion, I want to listen to them, see if they're wheezing or if the breath sounds are very decreased, if you will. I want to look at their peak airway pressures, etc. And the combination, if you will, the compilation of all of those factors, one of which is a shark fin capnograph, would cause me to say, this patient seems like they have an element of bronchospasm. We're going to, I'm going to recommend that they be treated, or if there's a protocol to actually, institute therapy and let the physician know, such as a therapist-driven bronchodilator protocol, then that should be considered as well. But again, not diagnosing the patient based on this, but also if they are an asthmatic or status asthmaticus or on a ventilator, etc., and you're seeing this waveform, don't be surprised if you see a waveform that looks like a shark fin. So some of the causes of an elevated end-tidal CO2 are as follows. On the metabolic side of the equation, you could have a patient who has what's called malignant hyperthermia. So you have, again, damage to the hypothalamus. So the body's thermostat is off. Patient is basically burning up. They're basically, producing a lot of CO2, and that CO2 could be measured in terms of an elevated end-tidal CO2. On the circulatory side of the equation, you have increased cardiac output with a constant ventilation. So the heart accounts for, in the range of about 25% of the oxygen uptake and about 25% of the carbon dioxide production. So you have, again, increase in cardiac activity. The ventilation has not increased proportionally, and you can actually have more CO2 buildup relative to the the body's ability to get rid of it. On the respiratory side of the equation, respiratory failure, whether it's it's some sort of hypercapnic respiratory failure, perhaps a pneumonia superimposed on top of a COPD. Some respiratory depression, again, could be due to medications, neuromuscular disease, or some other related cause. Overdose or sedation, so a accidental overdose or illicit narcotic use, or just sedation when it comes to patient being given moderate sedation to facilitate a procedure. And an obstructive lung disease I referred to a little bit earlier on, whether it's alone COPD or you have something superimposed on top of it like a pneumonia. And there's always the chance that there's equipment failure. So defective exhalation valve on, let's say, a single limb circuit. We don't see them real often. We do see single limb circuits used with certain BiPAP setups, non-invasive setups. For instance, the Trilogy ventilator / BiPAP, that can use a single limb circuit, and that exhalation valve can become, if you will, defective, or secretions could clog it up, something along those lines, which could absolutely cause the patient to rebreathe CO2 in an elevated capnographic waveform and numeric value. So causes of a decreased end-tidal CO2, pain and anxiety can, affect both the respiratory system and the metabolic side of the equation. With the respiratory system, patients in pain, they're breathing quickly, or they're anxious, they're breathing quickly, they're blowing off more CO2. So it's really alveolar hyperventilation, the two top, if you will, subcategories we have in this slide. Then beneath them, on the circulatory side of the equation, you're looking at something like a cardiac arrest, where again you have oxygenated blood that's not being circulated through the body, it's not being able to pick up CO2 and return it back to the lungs. With an embolism or blood clot, the heart may be functioning okay, but there's a blockage. There's some sort of a blood clot that's preventing, again, the oxygenated blood getting to the tissue, and that has the venous blood that has CO2 getting back to the lungs to be exhaled. Sudden hypovolemia or hypotension, whether it's due to blood loss, whether it's due to some other things like septic shock, whatever, but that can also cause a decrease in end-tidal CO2. As far as equipment goes, some of the things that we actually discussed previously in the presentation, there could be a leak in the airway system, a partial airway obstruction, or the ET tube is just not properly placed. It's not in the trachea. It's in the hypopharynx, or it's in the esophagus. So to come down the home stretch here, kind of summarizing some key points, capnography can be a useful assessment tool, but it's not perfect. Very useful potentially, but there could be equipment issues, there could be user issues, and you need to know how to, number one, interpret the result, and number two, once you properly interpret the result, be able to recommend changes that would remedy any abnormal values. In addition, understand that it's relatively simple and straightforward. Again, a valuable tool, and that a little knowledge can go a long way. But again, there's also indications, there's contraindications, there's limitations, and all of those things need to be kept in mind. Again, be able to hopefully begin to recognize more thoroughly the normal value and the normal waveforms, and then the abnormals, and some of the short list items of how to rectify them. And most importantly, if this topic is particularly interesting to you, you can go to some additional sources that will be able to help you out in learning more about these topics. Lastly, I just wanted to provide you guys with some of these selected references. The AARC, I believe we have all respiratory therapists that are participating in this session today, but if there are any nurses or any non-respiratory care professionals, the AARC is the American Association for Respiratory Care, and they have some very good resources on their website to actually help guide you, including that which pertains to end-tidal CO2. One of my textbooks, Egan's Fundamentals of Respiratory Care, we just came out with the 12th edition, literally in the mid-spring of 2020. It's a great source. I'm putting a plug in for one of my own textbooks, but it is what it is. Likewise, my clinical assessment in respiratory care, we're currently working on a 9th edition. Most recent edition is the 8th edition, came out in 2018. My dear friend, mentor, and colleague, Dr. Craig Scanlon, worked with me on it. He passed away now a little over 3 years ago. So the current edition I'm working on, when I say alone, I have a lot of very talented contributors. But it's kind of this edition and the last edition were dedicated to his legacy and all the contributions that Craig Scanlon made to respiratory care. And then there's another outstanding source, Respiratory Disease, a Case Study Approach to Patient Care, by Robert Wilkins. I believe that they're actually working on a new edition, even though it's been some time since this one came out. It's a great textbook that goes into the etiology, the pathophysiology, the clinical manifestations, and the treatment for all kinds of conditions, including respiratory failure. First two chapters are dedicated to respiratory failure, both oxygenation and hypercapnic respiratory failure. And then they actually cross-reference those two chapters throughout the rest of the textbook, which really is, basically is a highlight of the 25 most common respiratory diseases, and really drills down extensively on them. Lastly, and kind of combined PubMed and Medline. PubMed is really geared for more the layperson. Medline is more for the scientist. But you basically, a wealth of information on the most recent studies that have been done on a lot of these topics, including capnography. So I encourage you, again, if you have an appetite for this sort of thing, to drill down more on that. With that, Terry and I want to thank you very much for coming to this session. And we hope that you have derived some knowledge from this. We appreciate your coming to, the ensemble of CEUs that we've done today. And we really hope that you guys come back. Thanks a lot, and have a wonderful day. Bye.